I'd like to call the joint meeting of Internal Services and Health and Human Services Committees to order. And please rise for Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
James.
Thank you. The next item is to adopt the agenda. Do I have a
Romano,
motion?
adopt the agenda.
Support Zinner.
Thank you, Commissioner Romano and Zinner made the motion and seconded it. Is there any discussion? If not, please vote.
Motion passes 13-0.
Thank you. Next, item 4, approval of the minutes.
Motion to approve the minutes.
Thank you. We have Commissioners Groh and Perna making the motion and seconding it to approve the minutes from the joint Internal Services and Human Health Services Committees for the 10th of March. Any discussion? Please vote.
Motion passes 13-0.
Thank you. Item 5 is public participation. This is the first opportunity for public participation for those who wish to speak for a maximum of 3 minutes for anything on today's agenda. We'll have a second opportunity later for public participation for any subject. Public participation, second time. Any public? Hearing none, we'll close public participation and move to the internal services recommendations. First, item 6A is agreement for information technology. It's a maintenance agreement for the second quarter of 2025 for a total cost of $1,830,549.67 with Dell, Microsoft Services, LinkedIn, Mitchell and McCormick. Need a motion to move this to full board.
So move.
Support Lucido.
Thank you. Commissioners Hall and Lucido made the motion and seconded to move 6A to full board. Jaco, you're up.
Good afternoon, Commissioners. This is maintenance items, obviously. One of the biggest, I think it is the biggest one that we bring to you every year is our Microsoft agreement. So that's one of them. And then we also have LinkedIn Learning, which is the learning module in Workday. And then Mitchell and McCormick, who's our visual health net, the health net or health system. So those are the 3 different items for a total of $1.83 million this year.
Thank you. Commissioner Hall.
Thank you, Chair. Jaco, you're a very expensive guy. I just want to ask, we have LinkedIn Learning Workday. How is the implementation in learning of Workday going?
Well, it's working well. I think people can do their training and stuff that's assigned to them, can do it through Workday. It is just a module that we moved from a previous system. I forgot now what the name of it was, but moved from the previous system to this one. And, you know, it's assigned to staff as they need to do their learnings for the specific year. And some of them are done every year, some of them every 3 years, and it's set up in that manner. So whenever they come up, you go in and you do your training.
Thank you. That's all I have, Chair.
Thank you. Commissioner Wayne.
Thank you. It must be a popular topic because my question was a little similar, a little different regarding the LinkedIn Learning. Can you just, are those required courses? You mentioned that they're assigned, so I know we have, individuals that work in healthcare. I know that there's certain requirements. Is that what this is then? It's required courses that they have to take in a annual mandatory basis?
Yeah, so some of them are required and some of them are optional. So the required ones, that I can just think of off the top of my head is things like, for health, HIPAA training, especially when somebody starts here and they work there, they need to take the HIPAA training. And then people like in my department that work with that data, we have to do HIPAA training. So depending on what the organization want from us, we have to do that. There's another one called CGIS, which is for public safety. That one is ran by the state of Michigan, and we actually do it on their learning management system. So we don't touch Workday for that specifically. So there's very different ones, but most of them are in our LinkedIn learning system. And it's assigned to people, and then you have things like conflict resolution, for example, that some managers have to take, and at times they would provide those, and it's optional. You can decide whether you want to take it. But the ones that are mandated, they have to take.
And I'm sure it was in the packet and I might have missed it, but does LinkedIn, is it a charge per user or?
I think it's just charged per year. This amount that we pay here, that is our service for the year. And then we have somebody in HR that is in charge of that system, and they work to schedule those trainings, put them in the system, and then schedule if it's annual or every 3 years or whatever. So that's how we manage it.
Thank you. Thank you.
Thank you, Commissioner. You asked part of the question I was going to ask. For the other two services, Dell, Microsoft services in the Mitchell and McCormick, are those also flat fees for a quarter?
Yeah, those are flat fees for the year. But as you can see, the Microsoft one has one, what we call a true up. So as our users increase throughout the year, or we needed more license for whatever reason, they do a true up at the end of the year, and rolled into that cost this year, I think it's something like $65,000.
Okay.
So that would be for additional licenses that we consumed over the past year.
So you referred to these as for the year, and the title says maintenance agreements for second quarter. So I should read that as maintenance agreements for the year coming due in the
For
second quarter.
2025, that's due in the second quarter.
Okay,
Yeah.
thank you.
That's probably a good idea for us to change that, so it's more clear.
Commissioner Sabatini?
Thank you. Hey, Jaco, the
Commissioner.
true-ups, you do those just annually?
Just annually,
Okay, and
yes.
then they're trued up in your second quarter, typically back in the contract?
Yeah, so how they do the true ups, if somebody arrived at the county in October, and the true up is always in April, May, you just pay for October till then. And then obviously the next year would be a full license. So
It's not a calendar year basis?
Yeah.
Or it is?
It's on a calendar year basis, but they prorate it if a person starts later than the
Got it.
calendar year.
Okay, thank you. Thank you, Chair.
Seeing no other speakers, please vote.
Motion passes 13-0.
Thank you, Commissioners.
Thank you. At this time, it's my pleasure to turn the gavel over to the Chair of the Health and Human Services Committee, Commissioner Lucido.
Thank you, Chair. And I will open the Health and Human Service Committee meeting, and we will start with item 8, which is presentation. Can I get from Martha G. Berry scheduled report? Can I get a motion to receive and file?
So moved.
Support. Ken can support it. We're singing here.
Hi, Kevin, how are you?
Great, Madam Chair. Thank you. I'm glad that there's enthusiasm to get this approved.
Really fired up to see you today.
Could be because it's the last item, we can get out faster, is that?
Well,
I'll try
we'll
not
item
to be
after you.
too verbose on this. All right, so last month, at the last presentation, we talked a little bit about how a medical care facility comes to be and what our relationship is with the county. We spent a little bit of time on that. My goal this year, in addition to giving you the information you need about what we're doing month by month, is we have a lot of new members, and it's good to kind of run through some of this information as to why we exist and how we work and why we're different than the departments inside the county. So this presentation will include what makes us different. And then I'm coming back again in July, and that'll be a little bit longer conversation because that'll be talking about money, how we get our money. I know, Commissioner Romano, it's a tough one to talk about, but what we have to do is make sure that you understand where how we are reimbursed, why we have from time to time struggled, and why we have had some success, and just so you know where the money comes from, so you're better informed when it comes time to making decisions about Martha T. Berry. For now, our census is staying strong at 202. We're at 93%. We do have 2 beds that we keep offline. So even though our census could potentially be 217, we still have a lot of catch up to do on maintenance inside the rooms that we weren't able to do during COVID, which is hard to believe that it's 5 years behind us now, or since its inception. So we have a lot of makeup to do in that. We have, again, you take a look at the state average, it's 74%. Now that is according to the certificate of need, and that's the beds that are licensed versus beds that are available. We'll talk more about that in a little bit. I've included a snapshot of where we are financially. This was close to the first quarter being done. We got this printed off so that we could get the report over to you, but you can see our expenses year to date are about 7.7 million on a budget of 39 million. So we're tracking really well in terms of our finances. If anybody has any questions specifically in that area, please let me know. As far as the county's building, we actually are inside a building that is owned 100% by the county, and we are charged to maintain that. And we have, I'm pleased to say that on Friday, I'll have been here 9 years, if you can imagine that. It's pretty amazing. And since that time, we've put in just under $12 million into the building. And we did have some help with a 0.1 mil millage a few years into it to help us with a few things. That was a huge help. And we'll talk more about money when we come down to it. But there has been no dollar since I've been there put in for operations. And that is that's with intent, both with a joint operating agreement that says the county won't provide operational money. Also, it just is good business sense to be able to run it. We have to run this like a business, not like a department where we say these are the services we provide and we appropriate taxes. We have to bill or find grants for the vast majority of our operations. The physical plant, however, is a pretty complex thing, and we'll talk about that more later. But we do take good care of it. When I first got here, the building was in poor condition. I'm sure that if people were over there back then, you would agree. We had a lot of issues with infrastructure as well. But we have invested in plumbing and electrical, bringing the water up from inside a tunnel to overhead so we can see where the pipes are. The same with the electrical, which we had lots of problems and OSHA issues with those trapped spaces. We've just eliminated the need to have the tunnel entirely and brought all of the infrastructure above. Most recently, we replaced the heat exchanger, which was cracked, and that can cause some real issues if it isn't repaired in carbon monoxide poisoning. We took care of that. Our open projects right now are emergency power. That's a fun time. I'll say that right now, working with the county on trying to get the jail done and still run our operations. We're talking almost daily with their project manager about how to redirect things there. The power, we're continuing to work on getting it ready. I think I shared with you that they did take the power offline to one of our emergency systems. We are putting the infrastructure in there, waiting for them to be done with their load tests. They wanted fresh load tests. They didn't actually have any from the last 10 years. We did have a couple of them because we were making some changes, but they wanted to get those fresh. And we're waiting on them for the final work in that, but we're not waiting on them to come up with the answers because we just need to be in compliance in emergency power. We have a therapy, a roof right over our therapy department that needs to be replaced, and we're taking care of that. I'll have some more details on, we have, actually, these are the higher level ones that we're working on. We currently have 25 projects that we're working on in total, a little at a time, and as, you know, doing time and materials to keep the building going as money and cash flow and things work. And we can talk more about that again in the next couple of meetings. So, why are we different? Many of your areas have nursing homes in, and you say, why can't my nursing homes do what Martha T. Berry does? Let's start about the difference in the classifications. The not-for-profits and the for-profits are what's called a Class 1 facility, and they get a calculation of their rate based on that Class 1. We are Class 3 facility, and we get more money specifically from Medicaid to be able to provide for those that are most at risk. So our mission, actually, according to the rule, and I'll read some of it at the next meeting, out of the Michigan compiled law, talks about we are in place, and we are established actually by this commission decades ago to be a safety net. For-profit facilities have a drawback in our perspective, in that money that comes into the facility has to go out to give an ROI, a return on investment, to the investors. And the only way that they can get more money is they expand, right, and they leverage, but they also have to pay taxes on that too. And they're already making less than we are. So when you hear the issues that I'm going to be talking about here shortly, you have to understand that I'm not denigrating them in any way. They have a very difficult charge to do, but they cannot do what we do because of the structure of the reimbursement system and their need to take money out to pay back investors. That's on the for-profit side. Nationally, according to the American Healthcare Association, 24% of the nursing facilities were forced to close a wing, a unit, or a floor due to labor shortages. To give you a perspective, this is not a new issue. In 1998, Michigan had 460 nursing homes, and now we have 424. When you see the ones that have closed, those are the ones that were primarily Medicaid. It makes it very difficult. COVID exacerbated the issue. This is a slide that just came out of a national program that I attended. And between February 20th and July 24, across the country, 774 nursing homes closed. I just attended Leading Age Michigan conference, and they talked about the need for their skilled facilities to get out of skilled care or greatly reduce it and go to assisted living and PACE programs, because the skilled facilities just cannot support it on a Class 1 money. They're all fighting for Medicare dollars, which are the higher level dollars, and the Medicare program can't sustain as many nursing homes as needed. So they're getting out of it entirely, in many cases, because of the reimbursement structure.
I don't have your name up here.
So now that comes at a time when we're getting old. If you take a look at this screen, we have roughly 72.1 million people be age 65 or older by 2030. And that 15% requiring long-term care is a solid number statistically over the decades. Pretty consistently, 15% of the population will need some form of long-term care.
Kevin,
Yes.
Commissioner Harold has a question.
Oh, okay.
Thank you, Chair.
I'm sorry. Yes.
Kevin, could you define a skilled facility for us?
Sure. That's a great question. Skilled facilities are defined as having a certification of Medicare. You can be licensed in the state of Michigan for Medicaid beds, but the higher skilled rating, which is the Medicare rating, means that you have an ability to take residents from hospitals post-surgical and have a higher level of skill inside your facility to do that. So we get licensed by the state of Michigan, But if we're going to be, and you can be a nursing facility, just an NF, but if you want to be an SNF, a skilled nursing facility, you need to be certified by Medicare, which is done annually. Here's the interesting thing. You cannot become certified unless you go through that annual recertification. But if you get decertified as a skilled facility, you will automatically lose your license as a nursing facility as well.
Well, thank you.
You're welcome. Great question.
Thank you.
And I really don't like hearing myself talk straight through like this. So if you have questions, I really appreciate that. Thank you very much.
That's holding all mine.
We have to make sure our chairwoman appreciates it too.
Till you're through, Kev, then we'll.
Oh, you want to muscle through and then you'll have the questions?
we'll get
Okay.
you.
All right.
No one wants to get yelled at.
Yeah, because I was told that this is the good group. That's what I heard. This is the one that's in trouble. That's what I heard.
Well, yes.
That's what I heard. The troublemakers are on this side. But that's what I heard.
From
That's what I
here
heard.
over.
That's what I heard.
Clarify.
The chair just tries to oversee it all, that's all. Yeah. All right. So here's the challenge. It stands to reason that if people are getting older and we have the graying of our population, also known as the silver tsunami, our workforce is also diminishing. And you can see that's what's happening without question. So that's one of the many reasons why the facilities around our area are struggling. They're struggling because a lot of the for-profit facilities are trying to expand and fight for the same Medicare dollars. At the same time, they're losing nurses because of the aging of population. COVID hurt us. It was called the Great Resignation, when it became clear that the federal government said you could only work if you get vaccinated. You saw, I'm sure you saw the paper where just, one hospital chain lost 1,400 RNs because they weren't going to get vaccinated. That happened all over in every sector. At the same time, the numbers of insurance companies are expanding and taking more RNs out of the workforce to work from home, to do case evaluations from their home. They're wearing their slippers and they're just looking at charts and saying, yep, qualified or no, not qualified, or auditing. So a lot of the workforce is coming out. So it's just a perfect storm. The challenge for the facilities that remain are they get the Medicare people in, but then they have someone that needs long-term care, and what do? They can't afford to keep them and fill a bed when they could get more money in, a lot more money in, if that bed is filled by a Medicare resident. And if that person is Medicaid, they're getting significantly less. So they need some place for them to go. Now, you would say, but the people in my area, they have Medicaid residents. Yes, that's because they need some revenue coming in while they replace it. But if you take a look at their census, they're doing it just to try and survive. This is a chart that we did a couple of years ago, and it has been consistent. I was asked by the commission to say, how many people actually do you care for in this community? But we get significantly more people coming to us from other nursing homes than we get from the hospital. For that very reason, their business model doesn't allow them to do it. And that's why the not-for-profits are getting out of it. 30 years ago, not-for-profits dominated the market. They had 3 out of 4 facilities, and now they have 23% of the facilities because they're just getting out of it. They're going to CCRCs and having a very small component of skilled on their campuses because of the challenges that I'm talking about here. So how do you know that we are needed? We've actually had a number of other skilled facilities sponsor our foundation and attend our foundation fundraiser. Now, you don't go to competitors' functions to help them raise money, do you? We're needed in the community because of this reason. Now, we can't take care of everybody, but we take care of the most sick, the most frail, those that are most, that others can't take care of. I don't know if you have heard recently, just in the last year, calendar year, Macaulay Rehab and Wellness over in Muskegon closed. But we also had St. James here in Detroit close and Mission Point of Beverly Hills close. Those were all Medicaid-specific facilities that just could not keep going. So we're needed for that reason. We're established for that reason by Michigan compiled law. And this county has been just spectacular over the years in making sure that the most vulnerable are cared for. And we're a component of that on your behalf. If you'll indulge me, I'd like to read this into the record because this was pretty neat. I don't know if you remember me, this came from a family member, but I was a guest that entered the recent Super Bowl party you guys organized and started to cry because I was blown away by the level and care and consideration given to the residents at MTB. You gave me your card and said to reach out anytime with questions. When I met you, my mom had only been at MTB for a few days. It's been over 3 weeks now, and we are so happy and relieved she's getting the care that is settled in. She's being well cared for. She just started to enjoy the activities in the community center yesterday. She attended afternoon entertainment on 226 and even got a pic with a performer. And she attended the surprise auction last night and had so much fun bidding on and winning the most adorable stuffed cow. We're so impressed with Lan and Cheryl. They were fun and funny and made sure each resident was included in the game. What wonderful women. They did a great job executing the event. My husband and I really had fun watching and helping my mom participate. She also really enjoys the pet visits to her room and the birds located on the third floor. And she beat us at a few games of the big Connect 4 on first floor. We're getting to know the wonderful Pink Party crew. That's our activities people. And just wanted to commend you on you and all your teams does to bring smiles and great memories to the MTB family. Can't wait for my mom to experience more. I want to share that with you because even though we take care of Medicaid people, because we make a little more money, we can invest in making life worth living. If you consider thinking about if your mom needs to go someplace, do you want her to go someplace where she is housed or where she is loved? Our staff love the residents there and do a great job. And I just wanted to share that with you. Thank you for the opportunity to share that and for indulging me. And again, thank you for your support.
Thank you, Kevin. We do have a few questions. Commissioner Howard.
Hey, thank you so much for what you guys do. I met, I'm drawing a blank on his name, Pat Thompson?
Yes, he's our board chair.
We just happened to be in a coffee shop, and I was just overhearing him talk about Martha T. Berry. I'm like, oh, who's that guy? And I don't know that he saw me in there, but we had this great conversation. He's been nonstop. You got to come down. You got to come down. You got to come down. So, Pat, I'm coming.
All right, pretty good.
So I just it was just exciting to see like his excitement for what you guys are doing over there. That was refreshing. To make sure I have a grasp on what you presented, how many facilities can sustain, like how many facilities are there across the county that can sustain like long-term care? Because based on the statistics, 15% of 65 and older, that's about 30,000 residents in Macomb County alone.
Yeah.
So what's the opportunities out there versus the need?
Well, according to the Certificate of Need program, we are overbedded in Macomb County because of their numbers are about 15 years old, and they have a process for that. What's trying to occur, what the whole state and the federal government is trying to do, is trying to move people down out of hospitals, out of nursing homes, into home and community-based centers. The challenge with that is exactly what I talked about, is that there just aren't enough nurses to actually do the home and community-based. I tried to discharge someone to a home base with a community-based waiver, a Medicaid waiver, and the company said, we're out of waiver slots. And I went, oh, that's unfortunate. And then I went and talked to the state about it, and they said, they're never out of waiver slots. They can have as many as they want to. But what they are is out of people to care for people. So when you say the opportunity, we have 35 nursing homes in Macomb County. But the challenge to that is, just right up the street here, there's one that's taken a whole wing offline because they don't have enough staff. So it's a more complicated question to answer that, we have this many people and we can take care of this many people. because we have the beds, the physical rooms, but we don't have is the people to be able to walk up and down the hall and care for people. So I've not done a deeper study in that, but what you saw on certificate of need, it says that we are only at roughly 73% capacity. But if you take a look at the beds that are offline, we're closer to 15% off on capacity. We're like at 85% because they've taken so many beds offline. And the reason they like 85% is that's kind of the sweet spot for reimbursement on Medicaid. It's a very complicated thing. I won't get into that some more, but it's at least today. I'll warm you up for that for July.
Thank you.
But yeah, we have 35 nursing homes, but we're trying to get PACE programs, and I'm one of those rare people that believe in other than nursing homes. My job is to take care of this group, but I do my best to get people out of my building as much as we can.
Thank you. This came up with a resident I was having a conversation about. They said we have too many medical facilities all around us and we don't need any more, that we should close some of them down. And I was trying to explain, like, the need is still significantly greater than what we have the capacity for. So
It's
this is very
profoundly
timely.
greater. Yes. Yeah, it really is.
Thank you.
Yeah, you can take a look at the numbers and just see what's happening. And the problem is, well, the hospitals have the same thing. They say we're at capacity, but at capacity is different than are they full? And those are two very different phrases. You're not full, they're at as much as they can care for. I've got a couple of people on my boards that we have that conversation pretty often, that the hospitals are having the same struggle. Matter of fact, about 10 years ago, they were trying to get only RNs. They actually fired all the LPNs in the hospitals to say, we're only going to have RNs, and now they're hiring LPNs back because the RNs just don't exist.
Commissioner Wayno?
Yep, thank you. So thank you. I too agree that Martha T. Berry is a gem for Macomb County. So
Thank you.
I had a couple questions. You mentioned about Martha T. Berry's competition. Can you tell us who your competition is?
The answer to that is we don't really have competition because we are unique in the industry. We're the only one in the county, and we're actually the only one in Southeast Michigan that is an established county medical care facility. Oakland had one, and they sold it to a for-profit entity, and they converted it, and they actually moved out of the building that was brand new. It was like a year and a half old. They moved out of it and created an entirely new post-acute care, 100% Medicare only, and they're doing rehab exclusively. So Oakland lost their safety net, and that was one of the conversations we had here before is, why can't they take care of themselves? Well, they sold it. So, and now it's even more important that we're here because we don't have competition in that way. We have Medicare residents just like they have Medicaid, but we don't go after those Medicare dollars. We only do that when the residents say, hey, can we come to your place? So I actually worked with David Miller, who was the executive director out at the Villages of East Harbor. I worked with the Veterans Home, to try and get people into those facilities, when it makes sense, because Veterans Homes are right. So, we work as collaborators in the community, not as competition.
Well, that brings me to my next question, which was, you mentioned about, we prioritize Medicaid patients. I guess, can you explain to us how is there a flow chart that you use as far as who will be able to be admitted into Martha T. Berry? I mean, do you prioritize, for example, a Medicaid member that has a higher level of acuity that needs care over somebody that's could maybe be serviced at more of a assisted living facility? I mean,
that's a great question. We actually have something called doors that we do an assessment for, and they cannot, if they're a Medicaid resident, they cannot come into our facility if they don't qualify as skilled, as we talked about before. They have to be qualified as a skilled resident, but if they can get cared for in assisted living, we cannot accept them. We're not allowed to. That's a great question, though. But we have to do an evaluation on them and then discharge them
so
appropriately.
they do have to meet that skilled, and my understanding of a skilled facility or level of care, according to Medicare, is, I mean, they need nursing service, like IV
24/7,
therapy, something like that, or physical therapy, occupational therapy?
Yep, 24/7, yeah, required care under a physician's watch.
Okay, that's all.
Commissioner Romano?
Thank you, Chair. We got a list of them, Kev, here that want to talk to you or ask some questions. I'll make mine.
I have the
Make mine
time.
As short as you want. Do we have a lease agreement? You say the county owns the building. Do we have a lease agreement, a written lease agreement with Martha T?
Not that I'm aware of. We have a building use agreement that it was really convoluted, and I think it was done during the time of enmity. I think we could probably clear that up and make it a little easier for this commission if there is some thought to be able to modify that, because but we don't have a lease agreement. I will tell you, in my other two facilities, that's exactly what it was. It was $1 a year for 100 years, and it was just pretty simple, straightforward.
Okay, the responsibility of the maintenance to the building.
Yes.
You'd mentioned 25 open projects. Who's paying for those?
Right now, we are 100%.
Is that your responsibility?
It's my responsibility to make sure it happens. Yeah, no question about it. And the building use says that, talks about certain things. And to give you an idea, the curbs are my responsibility, but not the pavement. Some of the lights are my responsibility, but not the light fixtures. It's just really an odd,
So you have a lease agreement. There has to be something in writing if that's what you're telling me.
it's a building use agreement, but it's not a lease in that way. No. I'll send it over, for
If you don't mind.
refreshing, be happy to do that, yeah.
You mentioned those 25 open projects. Do you have a number that you're talking about dollar-wise that you anticipate you're going to be spending for these projects? I mean, just an overall amount, or have you itemized?
Yeah, we expect, we have a 5-year plan, and we're in the second year of that, just beginning that second year of it. So we're going to be reviewing that at our strategic planning sessions. But essentially, from our view, we have probably $13 or $14 million of stuff that needs to be worked on and repaired. And we also have probably another $1.5 million that we'd really like to do that, but we don't have to do it.
Okay. What's the percentage amount of seniors that you have in the facility? When I classify a senior, I'm.
Employees or?
65 and older. Pardon me?
Employees?
No, no. No, the people that you're taking care of,
Yeah,
how many are seniors,
our seniors.
percentage-wise? 10,
Percentage-wise?
20, 40,
Define seniors as over
65?
65. That'd be closer to 98.
98% of your people are over 65?
Yes.
Now you're blowing me away. All right, and what happens when your facility is full and you have to turn them away? Have you ever turned them away?
We put them on a waiting list. So to answer, Commissioner, is it Wojno?
Bueno.
Wojno, thank you. My apologies. Wojno, we have a hierarchy when we are full. And that is, first, we're required to take from a hospital. And then the next, we're required to take from the county. And then in that county, we look first for Medicaid. So we look at indigent status, and then we say, do we have the capacity to care for the person? So if that person has, a trach, we can take care of them. If they have a tube feeder, we can take care of them. If they're on a vent, we cannot take care of them. So those are things that we look at and have that checklist that say yes, 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 no. Is this a no-go? Can we get services in another way? And if not, then we have to say, no, you need to go to a vent unit, or in some cases, they're violent. We can't accept those unless they have a regimen that has been proven to be effective for the psychosis that they're in, because we can't take psychotic people into our building. It's actually a code as well. But if they're on a drug regimen that is successful, then we can do that. That's so.
Okay, how many open beds do you have right now?
We have 15. We have 2 offline, so a total of 13 that we could fill.
Good. That's all I have. Thank you, Kevin. That's all I have, Chair. Thank you.
Commissioner Goyke?
Thank you, Madam Chair. Real quick, you got the 3 classifications of those type of facilities. Is the FTE to patient ratio any different from class 1, 2, and 3? Or is there a state
Absolutely.
mandate on that?
Absolutely, yeah, thanks for asking that. There's a state mandate that's the same for everybody,
Okay.
but in terms of executing it, significantly different. We're in the top 6% in the state and nation on FTEs, on providing direct care. They only measure CNAs, LPNs, and RNs on that with a national standard. Everything else is up for grabs. So if you take a look at cleanliness, you take a look at food service, those all are based on management activities, for example. And when I first got into long-term care, I was really young, and I saw that the activities budgets were just below the coffee for the administration. It was just no budget. They had to do bake sales just to be able to have a party. So it has to do with, and in the skilled facilities, the for-profits, they really squeeze what they can because they have to have that ROI. So the FTEs are significantly different. There are a few facilities that really do a good job, and the chains that do a good job, they do a really good job. But there are some chains that just don't know how to manage that, and that's where the FTEs are dramatically different on a scale for direct care.
Okay, so getting in the weeds on that now. So, is Martha T. Berry saying that we have to have LPNs instead of masters or
Our registered nurses? What we're saying is, that's another good question, because we're not saying we have to have those, either or. We'd like to have both, and we'd like to have RNs as well as LPNs there. As a matter of fact, we're graded on how many RNs we have. That's the number one rating. Even though we're the top 6%, we're only a 4-star because we don't have as many RNs as they want us to have. So I will take all good, competent people that love residents. And what I would prefer to have RNs whenever we can, but we've got some great LPNs that came up as CNAs, and we're actually graduating a couple of our own CNAs that we helped get their schooling in. So they're going to be starting an LPN here pretty soon.
Okay, thank you, Madam Chair. Thank you.
Great question.
Commissioner Sabatini.
Thank you, Madam Chair. Hi, Kevin. Hi. Great to see you.
Good to see you too.
First of all, just a couple of things. First of all, Kevin and I had a meeting, last month, I think it was. We had a chance to sit down and talk about Martha T. Berry and just in the context of everything outside of, board and everything like that. And it was a really good conversation. I know I've told many of you now that I've pledged to meet with all the countywide on a quarterly basis. And I'm also going to be doing the same thing with Kevin, just so that our relationship can get stronger and that we're more aware of things in conjunction with Commissioner Zinner being our liaison with Martha T. Berry, which Kevin was very, very happy about that as well. But, a couple things in regards to what Kevin said earlier. Yes, Martha T. Berry it's a business in itself too, and he's running it like a business. And, when you look at his numbers operationally, the facility sustains itself operationally. He does come into situations where he does have capital projects that, are pricey, like we're dealing with a lot of our capital projects. So he understands that those are certainly challenging things. So he's been able to maneuver that and work with the county and FNO, and we're going in the right direction. So it's all positive stuff. I know next quarter or next month when you're coming back to talk a little bit more about finances, I was looking at your budget today, and I know in like your repairs and maintenance, there's about a $2.5 million upswing for this year's budget. And if you can just let us know specifically what those big ticket items that are in there, because when I look at that, I look at that possibly being more of a capital outlay item rather than just your normal repairs and maintenance on an annual basis, just so we can kind of see what you're looking to do there in conjunction with what you already presented today. And the other thing too, Kevin, thank you for sending me the financials. I did share that with the board. It was actually on Commissioner Kraft's committee yesterday. So we did share those with the board. And if anyone did take a look at it, it's in conjunction to what's in the budget. So they're doing a very, very good job. And Kevin, congratulations on your 9-year anniversary.
Thank you very much.
Thank you, Madam Chair.
Commissioner Ha.
Thank you, Chair. Commissioner Romano talked about a lease. I think if we're going to send what could be a lease or not be a lease, you need to include the JOA with that as well. So
A
that
great call,
they get
Commissioner Hall,
the
thank you.
Opportunity to see the
Yep.
complete picture, the joint operating agreement between the county and Martha T. Berry.
Yes, those two agreements are unique in the county. There's 34 other facilities, and there are no other county has a JOA and a BUA, Joint Operating Agreement, Building Use Agreement. But I think it would be good for especially the commissioners that haven't been here a while, or are new, to be able to see. Again, I think I shared briefly that those were developed in a time where there was a lot of stress between our organization and the county exec's office, and the county commission, stepped in to say, hey, let's go ahead and make sure that we keep Martha T. Berry established, and the JOA does exactly that. This commission, and I want to be clear on this commission has full authority to say Martha T. Berry will no longer exist. I prefer you not to do that. But,
well, you didn't have to tell anybody, but okay.
Well, but Commissioner Ha, I really do focus on as much transparency as possible.
Yes, we know.
I also know that I serve at the pleasure of my board, and my board serves at the pleasure of you. I'm grateful for that support, and but I also recognize authority. And if you say it's time to say goodbye, I will say goodbye. But I hope that's not for a while. My goal is, if the board's willing to be here about 6 more years, then I'll have been here 15 years. We'll be a 5-star facility. The physical plant will be in above average condition, and I can drop a microphone.
Yeah, thank you. That's all I have, Chair.
Thank you. Commissioner Van Sickle?
Thank you. Good afternoon, Kevin.
Good afternoon.
You've mentioned a waiting list a couple of times, and if I understood your numbers right, you have 13 available beds.
Yes.
Does that mean there's no one on the waiting list?
That is correct. We're still doing tours, and we're still getting referrals, and we're admitting. But as we had talked about earlier, we have the frailest of frail. So, we said goodbye to a couple of our residents that have been here a long, long time, last month. And right now that is, in the first quarter of the year, that happens more often. But yeah, we have those available. As we get closer to 210 and 212 in terms of our census, we sometimes have a male or a female bed waiting list, because we only have a certain number of female beds available, a certain number of male beds available. So we still have a policy not to commingle sexes in the same room.
So once somebody's in a room, that room is whatever sex that person is?
That is
and
correct,
the open
yes.
rooms are up for grabs?
That's correct.
Okay. Do you know how many or what percentage of the population is Macomb County residents before they were admitted?
That's a great question, and I don't know the answer to that. I did those numbers a couple of years ago, and I think it was in the 75. Yeah. 3 out of 4 were there.
Change.
Yeah, things do change. But
If you could pull those numbers again, and of course, when you have openings, but if you were to develop a waiting list, would Macomb County residents on that waiting list be given priority over non-Macomb County residents?
every time, yes.
Good.
Yes, Commissioner, yes.
Thank you. Thank you, Chair.
The only exception to that is if they're coming from a hospital. We're required to take people from the hospital regardless where they come, and if the hospital discharges us and we have a bed available, we have to take them. That's the only exception to that.
So if you don't have a bed available, what does the hospital do?
Go to another facility.
Go to another care facility?
Yeah, so they'll keep, so the whole process is they start shopping right away, so we're not the only people they talk to. And they require a response within 30 minutes, yes or no. So we have to, for the hospitals, we have to turn that around pretty quickly. And the rehab places, Henry Ford has their own, the Shelby rehab. They have probably a 98% census because they have a direct feed from the hospital. But for those that don't make that, from McLaren, Macomb, and some of the Ascension, when they discharge, they send it out on this software program. It pops up, and we go, hey, we got this. We get it to our clinical team, we get it to our business office, and we come back together and make a decision if we're able to care for them.
Thank you.
Welcome.
Thank you, Chair.
Commissioner Zinner.
Thank you, Chair. I know we've wrestled with budgets here for the county, and Kevin wrestles with budgets for Martha T. But there are some things that we've been hearing about for the going into 5 years that a few of us have been here for, and others, of course, longer. And so in regard to maintenance for the facility there, and I know the money structure is always a question, what can we do? What can we do? I'm just saying, I think that some of these things, he's working on things that are state mandated. I know that. We all know that. But trying to get these projects done on a timely basis, because as being state mandated, if somebody walks in, it could be a problem. So that's of concern to me, and I'm sure everyone else here, because we want things done properly. I wish some of these things, when it's going on these many years, that you'd like to see it finished, but we all have budgets to monitor. Do you have part-time nurses and CNAs?
Yeah, ironically, when I first got there, 95% of our staff was full-time, and now it is a 60-40 split of full-time to part-time people. We have a significant number of part-time employees there.
Yeah, hopefully someone who wants a part-time job would, be aware that it's not just full-time. That is, because I know it's such a pleasant place to be. People think that probably isn't true, but it is true, because several of us have been there and seen that. So anyway, thank you very much, Kevin, for everything. Thank you, Chair.
Thank you.
Commissioner Perna.
Couple of statistical questions. You have Medicaid and you have Medicare.
Yes.
And when the residents come in there, it's not their last stop. Martha T-Berry, correct?
It depends on the person. We tend to be the last stop because of the nature of what we do. We're not a rehab facility, a purely rehab facility, and we don't market to that. We hope that we can get people back home, but our discharges, we normally get the sickest of sick from the community. So in many cases, they're at our place as their final home.
If they're discharged and they go home and they have to be readmitted, do they have priority?
Again, it depends. We'll always want to take them back if we can, because we want to care for them. But it depends on that same thing that we talked about before. So, a rare example is someone from Oakland County, a male from Oakland County, we discharge them. And now our male beds are full, and 3 months later he says, can he come back? Well, I have to take a look at, do I have anybody that is in Macomb County that is a male that needs this bed and not a hospital? So we have to go through that same fair and consistent approach. And I'd like to be able to say, yeah, you get VIP treatment, when you were there one time, but we have to stay consistent in our analysis because of the nature of who we are as a class 3.
So statistically, their last stop is what percent, you say? 90% of the residents?
I would say, yeah.
All right, thank you.
All right, we'll start round 2 with Commissioner Goike.
Thank you again, Madam Chair. Just a real quick question. A little bit of backside. I've been dealing with these facilities because of elderly family members for the last 10 years, and you impressed the heck out of me. And I just want to find out, are you mentoring anybody as a deputy, so if something happens, that we can continue having support for the facility with somebody like yourself?
That's very kind of you, and yes, I am, Commissioner.
Okay, that's all.
I am working on a succession plan right now at multiple levels, myself included, so.
Thank you.
Yep.
Good leadership, then.
Thank you.
All right. Seeing no other speakers, thank you again. You always do a fantastic job with your reports. We appreciate it. And taking the time to answer everyone's questions, so thank you.
It's absolutely my honor to be here for you.
And for all of the commissioners that have not done the tour over there, you guys definitely should, because it is a really remarkable facility. Just hearing it, seeing it, you'll even be more impressed, so thank you.
Thank you.
All right, we please vote?
Great report, Kevin.
Thank you.
All right, moving on to item 9, a budget amendment for a fiscal year 2025, MDHHS Comprehensive Planning, Budgeting, and Contracting, LHD Grant Amendment Number 2 in the amount of $996,822. Can I get a motion to recommend to full board? So moved, Wallace. All right, we have motion by Wallace and support by Wayno. Director Cox is not able to attend today. He was asking if we would be willing to put it onto next week's full board agenda where he'll come and speak about it at that time if everyone feels comfortable.
Okay.
All right. Can we please vote?
Motion passes 13-0.
And at this time, we'll go to item number 10, which is public participation. This is an opportunity for the public to participate for a maximum of 3 minutes on any issue. I hope everyone's slowed down. We're running up here into the
James
podium.
might want to say something. He's the only public here.
Who?
James might want to say something.
James, you want to say something? All right, and we will close public participation, move on to commissioner comments. Commissioner.
Real quick, just because I think we missed it yesterday, but I want to wish a happy belated birthday to Commissioner Howard.
Oh,
Thank you, man.
Birthday.
You're finally legal, 21? Oh.
James thought that was funny.
You never.
Thank you, and our staff sent me a birthday card, and so I appreciate that. I was going to go around and say thank you today, but thank you.
Comments from the Centurion.
Commissioner Zinner.
Thank you. Do you see the, that I pushed this button? I can't see it. Anyway, thank you. Just wanted to say that at the Harrison Township meeting I was at most recently, they have something called, they voted for something called Ready Rebound. I don't know if anyone else has heard of it. It's a company that gets appointments for, in Harrison, we have the county as the police agency. So that is not in it, but it would be for first responders. And so the fire department, as they work, they may be getting hurt during their work. They may have a twisted ankle, whatever. Sometimes it's dangerous, of course. And so this company provides, they go to the best care, and the supervisor will call, I believe maybe the person, and they get them in immediately as professional athletes. There's no waiting for anything. You see the doctor, you get to put therapy or whatever the situation is. It's that kind of setup. And so that you don't have to wait for a month to see a specialist and that kind of thing. And they're expecting, they felt this was important enough for their workers in these situations, and it's called Ready Rebound. They're connected with a couple other places, and they feel that they're looking forward to seeing how this works for them. It's a 3-year expectation, but you can pull out in 1 year is what they're expecting. So that's what they're doing here is Ready Rebound. That's what I have for you. Thank you.
All right, thank you. Commissioner Van Sickle.
Thank you. I'd like to suggest that Deputy Cox gets a succession plan and be able to have somebody stand in for him so that next time we don't have to break our rules to accommodate his schedule.
Right. All right.
Thank you. That's
Thank
all
you.
I have.
Seeing no other speakers.
Motion to adjourn.
Support. Oh.
I think that was Romano and Wallace.